so, but I'd like to show some of our results or the experience, and that's cell therapy in clinics. Well, this is a financial disclosure to make, and several companies' name highlighted in block letters are relevant to this presentation. Well, neutropendocel. So this is a name, the product name, the Biznova. That is about a couple of years ago, the Japanese Ministry of Health and Labor and Welfare approved this product as a regenerative medicine product for treating corneal endothelial failure. However, the last September, the government also sanctioned government-supported health insurance coverage for this product. In addition to that, newly established surgical fee for the transplantation of these cultured human corneal endothelial cells. So therefore, this transplantation was performed for just 24 cases of corneal endothelial failure at the 10 Eye Institute in Japan. That because in September, so the company only prepared for like 25 cases of that. So that is why. So that this year we are supposed to have around 200 cases for this procedure. So how we do this? Preparation of this cell suspension just before the injection of these cells. These Biznova is coming as a 400 microliter suspension of the cultured cells. But before that, and we gently, I think, pipetting to make the single cell suspension and load it to the 1 millimeter syringe. And they are supposed to have the dead space-free syringe and 300 micro solution that is containing 10 to the 6 cultured endothelial cells with also the low kinase inhibitor. So this is a kind of picture. This is a pseudophakic villus keratopathy after the cataract surgery. So therefore, it's easy to remove the epithelial cell first to visualize the posterior surface. This is the small incision and using the silicone needle, irrigation needle, and try to scratch the posterior surface of the cornea. Generally speaking, we try to polish the around 8 millimeter in diameter. We are not so sure whether the endothelial cell is still present or some of the extra matrix is there, but to try to clean up on the descemet membrane. And then using the vision blue staining and try to visualize. And then in our cases and in Japanese, so we do twice or 3 times just to make sure to clean up. And then stitches, one portion, maybe we do not need it, but because of the cell products is expensive, so just to make sure that there's no leakage. So anyway, and then inject the cultured endothelial cell. This is about 300 microliter. So try to collapse the anterior chamber, and then 300 microliter is a bit more. So increase the intraocular pressure, and then after that, and face down position for 3 hours. Face down position for 3 hours. Now that is a bit tedious way to do that, but based upon animal experiments, at least we may shorten up to 2 hours, but not 1 hour. So this is I'd like to show you 3 representative cases. This is in my hand, and pseudophakic villus keratopathy, and I've already showed you in the video, pre-operative, and this is 3 months post-operative. So something like that, and 6 months post-operative, and he gained a 20/20 vision. Corneal epithelial cell epithelial edema is gone, and the endothelial cell density is about 2300 cells per square millimeter, and the corneal thickness come down to within a normal range. This is 76-year-old male. So endothelial cell density is more like that 3 months post-operative, but still a coefficient of variation is large, but it is gradually, I think, with changing the arrangement. So this is a case 2, D-sec graft failure. This is not by the graft endothelial rejection. This is just a chronic the failure of that. But there's no glaucoma operation episode. Pre-operative and 1 month post-operative, 3 months, and he got about 0.7 in corrected vision, and the corneal thickness also come down, although this is a DSEC procedure, so therefore thickness is still 658 micron, something like that. So the case 3 is the PKP graft failure. I performed the femto PKP, I think about 10 years ago, and this is a preoperative 0.07, and I performed, hopefully enough, she got like a 20/20 vision on PKP. But when she received the COVID-19 vaccination, about 2 weeks later, she suddenly developed the endothelial rejection, and that is irreversible. So therefore, we asked for her to receive this procedure. So this is the 3 months post-operative. So I think to me, the corneal thickness come down to within a normal range, but well, for instance, a repeated corneal graft, and we try not to do that, and I'm hesitant to do that. But the single injection of the cultured cells, and that could, I think, kind of reverse the corneal corneal transparency. So, and also we understand, although we inject the allogenic cells, not the autologous cells. So you may argue about what about the endothelial rejection occurred after cell injection. But we also had some of the results. ELISpot assay against the interferon gamma confirmed that no antigen recognition occurred by the host. So when we inject the cell, allogenic cells into the anterior chamber, not only for anterior chamber associated immune deviation, but also antigen itself is very, very rare to recognize by the humans. So we published this paper in the scientific report about a couple of years ago. So we are safe enough to inject allogenic cells. And so far, in our experience, about 100 cases or so, there's no endothelial rejection occurred after the cell injection. So when we are talking about corneal endothelial dysfunction or the failure, in an Asian country, I think we are still dealing with the PBK, with the glaucoma bleb, or the corneal graft failure, not much of the Fuchs endothelial corneal dystrophy, pseudophakic Bierschat, obviously, after the cataract surgery, something like that. But the Caucasian European or the US people, they are mainly targeting the Fuchs endothelial corneal dystrophy for the treatment of the endothelial transplantation. Well, we at least we are aiming at the global standard medicine. So in Japan, using the 65 cases, and we performed phase 2 and phase 3 clinical trial. During that time, also we prepared the cultured endothelial cells in a flask and shipped over to El Salvador. And then U.S. surgeon came down to the El Salvador and performed the 90 cases of this cell injection therapy. This is more like a repetition study, whether that is really working even in El Salvador. So they confirmed the result is right in our hands. So then after that, then the company named Orion Biotechnology made a lab in Boston, and then they performed the US and Canada phase 2 clinical trials, and that was, I've heard, successful. So and then they are planning to have the phase 3 clinical trial in a very near future. So I think I received this slide from the Orion. They had like 5 arms, very complicated because the FDA is different from the PMDA. So they use 3 different doses, and also low kinase inhibitor alone, and also the cell itself alone. So something like that. But the 1 times 10 to the 6 is the best result they received. So this is the Fuchs dystrophy, and then I injected cultured endothelial cells, pre-operative and post-operative. But at that time, we polished, not removed the Descemet's membrane. Probably the Japanese Fuchs endothelial dystrophy is not so severe as compared to US or the EU or the India or something like that. So, so there's some kind of argument. The polishing, do you think you could remove the gute? Yeah, well, I think we understand that. But in a clinical trial, we have to have one protocol, so just a polishing. So therefore, we did that. So the upper portion is the preoperative, and two different kinds of the Fuchs dystrophy, I would say. And the polishing and the lower portion, the right-hand side, please see almost all good day is gone, diminished. Although there's something in undermined desmoid membrane, but the other portion, about half of the good day is gone, but still there are tons of the good day over there. So we published the one paper in the JAMA Ophthalmology last year, and please take a closer look at this. And this is the that portion is the central part. This is the peripheral part, and you can see, and this is a kind of I don't know. Well, that's okay. The kind of the border of the polishing, and then from the center to the mid periphery, you can easily see there's a most of the guttae on the desmoid membrane is already gone, but there are tons of the guttae in the periphery, untouched area. So based upon the George Waring's EM picture many years ago, 1970, 80, something like that, and he divided it into three groups of the guttae on the desmoid membrane and in the desmoid membrane and undermine the desmoid membrane, something like that. At least on the desmoid membrane, these guttae can be removed, I think, based upon our clinical experience. So, but we could also perform the cell injection with the desmoid stripping only. Very limited cases, but this is a case, and Fuchs dystrophy pre-surgery, and then 2 years post-surgery. So I think in the future, probably the many, I think, surgeons in the U.S., and they are willing to do that. So probably DSO with the cell injection, really depending upon the patient's situation. So I like this seasoned soil hypothesis. This is proposed for the cancer metastasis. But when we are thinking of the fate of corneal endothelial cells after the cell injection or endothelial transplantation, always that is dependent upon the seasoned soil. In this case, seeds is a quality of the cultured corneal endothelial cell. Soil is an anterior chamber microenvironment and also the disease of the corneal endothelial cells. For instance, soil, this is just a personal feeling. Good soil, I would say FECD, Fuchs dystrophy, or laser-induced bullous keratopathy, these are rather good. Moderate is the pseudophakic bullous keratopathy or the pseudoexfoliation syndrome related to bullous keratopathy. But bad soil is a multiple surgery related to bullous keratopathy or the glaucoma related to bullous keratopathy, something like that. So in this case, even though the seeds are okay or so-so, but still that product can be applicable to treat the good soil. However, we really want to treat the good, moderate, and the bad soil. So in this case, the quality is a key. So we always think quality of the culture endothelial cell is a critical. So what future we have to do that? Mass production and donor selection of the cultured endothelial cells, or storage and transportation for cultured endothelial cells. That we could freeze the, like with the DMSO, that could do it. That could do it, but but I think it's still the quality problem. There are some of the quality problem, but also the long-term maintenance of the cultured cell suspension. Now we can use up to 48 hours or something like that. But if we can prolong for about a week or so, everybody can use in a worldwide basis. So. And by manual technique, we have to think about that, and a triple procedure with a cataract surgery, or I think a transplantation with a DSO, something like that. So I think presumed benefit is a very few rejection, and also I would say that this is starting from the very young donor cornea. So that means rejuvenation of the posterior surface of the cornea, and also I would say safety procedure. So I think this is our group. Thank you very much for your kind attention.
Wow, Shigeru, what a great talk. And I'm so excited by all this. I really am. Because, well, it's, you showed us there, it's so technically easy to do the operation of injecting the cells. It seems like something you could almost do even at the slit lamp. But my question for you at the moment, in 2025, many of us do not have access to the cultured cells. How about, what is your feeling about just trypsinizing the cells from a donor cornea, or even two donor corneas from the same patient, or different patients even, and splitting the cells down that way without, is it something we can do in a simple way locally?
I see. So I think the Jot Mehta in Singapore, he is trying to make such kind of things and obtaining the rather higher senior age the donor cornea or so with the low corneal endothelial cell density using the two donor cornea and try to gather these endothelial cells not in culture and then make the cell suspension and then try to use these cells injected into the anterior chamber. That was partially successful, I would say, in an animal experiment. And he's about to start some of the clinical trial.
And Shigeru, how about cell lines? How about pluripotent stem cell cultures and endothelial-like cells rather than endothelial cells? It's interesting that you get no rejection with donor cells, but
yeah, well, I think there's one way, for instance, started from the iPS cells or something like that. But I think for us, we could generate cultured cells for 3,000 patients started from one donor cornea, and then also we can freeze them like passage for something like that. So now the government, Japanese government, accept only up to the passage 3. So this is more like a regulatory issues. Scientific, academic science, we could perform the more than that. I think 3,000 started from the one donor cornea. I think that's we are quite confident about that. And then endothelial cell-like cells, I think I'm that's okay, but I have some of the fear about the some kind of adverse event because these cells, they may easy to cover over the meshwork area or something like that. So that is more, I think, thinking about the adverse. So the quality, the mimic to the healthy corneal endothelial cells in vivo. So that's a way to do it. But this is just my beginning point, ours. So I think somebody will, I think, at least fix it or some of the make some kind of progression.
Well,
Yes.
I'm already amazed that you can get enough for 3,000 operation from a single donor. I mean, we tried endothelial cell culture. This is quite a few years ago after we visited Nancy Joyce, and it was kind of witchcraft then. It was very difficult to do. Can you, without giving away any secrets, are you able to tell us the main things that you have changed that have made endothelial cell culture easier?
Well, I think at least the use of the low kinase inhibitor, the continuous use of the low kinase inhibitor. That is the one way, and also the second is the a kind of donor selection. We used under the 25 years of age of the donor cornea, and I think teenager is better, but we still do not know the why they are so good as compared to the ordinal 30 years or the 40 years.
Right, interesting, really interesting, because we would all love to have access to the cells so we can do this.
Thank you.
If I may just ask one question to Professor. Very nice talk, and of course, we are looking forward to this therapy. The Rho kinase inhibitor in this therapy is only used per operatively, where we inject it with the cells. The Rho kinase is injected with the cells. post-operatively, do they have any role when the patient is in the post-op?
Well, I think theoretically, if we could use it, that would be ideal. But almost always, because of the clinical trial, we cannot use it. So that's why we avoid to use a low kinase inhibitor. So the PK, endothelial transplantation, cell injection, whatever, they are supposed to have some kind of endothelial defect somewhere at the very initial point. At that time, I think low kinase inhibitor has to be very effective.
One more question? Okay. Professor Kinoshita, you mentioned that some of the cases where you use a silicone tip to scrape off the Descemet's membrane, the Goutte had reduced. Now, do you think so? Because I think the whole premise of DSO is that you have to remove the Descemet's membrane. So if you can just, from stripping, you can probably just modify it to just scraping. Would that outcome be better with rho kinase? Because the thing is, we know that the endothelial cells migrate much better on Descemet's membrane compared to on the stroma. So what is the need to really strip off the Descemet's membrane? Because if you're reducing the Goutte, probably that could be another alternative.
That is really true. But I think before some kind of a treatment, DSO or the polishing, if we could detect that this Fuchs dystrophy, Goutte can be removed by just polishing, but not this case. So based upon some of the fancy instrument or OCT or that or whatever, if we can divide it into two groups, and then I think you are right. So that's what I thought.
So Shigeru, with thanks, that leads us beautifully into our last talk of the session, which is also a really interesting topic, which is, do we have the AI tools to give us the disease classification that's going to answer your question?
Yeah, well, thank you so much.